Dear doctor, I have a son who is 3, who always has a running nose. He speaks as if his nose is blocked and breathes as if he is snoring. He also makes sounds as if he has stopped breathing when he's sleeping. Some people are saying it might be asthma. Others say hay fever. Others are saying it is just an allergy. Is this something I should worry about, or he will outgrow it?
In any human being, you'll find what we call adenoids. They are part of what we call the lymphatic tissues that we find inside our bodies. The main function of lymphatic tissue is protection from diseases, from viruses, bacteria, and so forth. So with the adenoids, they are part of the tonsils. What we call tonsil tissue. The other name for adenoid would be nasopharyngeal tonsil. The adenoids, what we call tubal tonsils, the palatine tonsils, the lingual tonsils, they form a ring around the area of the mouth, the entrance through the mouth and entrance through the nose. Their function is thought to protect what we refer to as the upper aerodigestive tract from things that are from infections that are coming in through the mouth and the nasal cavity. So in why do we talk about adenoids in children? It's quite a very common problem. Why? Part of it being because, you see, children are quite very prone to upper respiratory tract infections, of which problems with the adenoids, they also come with that. So in a nutshell, that's what adenoids are. So this is tonsil tissue that you find at the back of the nose. So in general, it is normal for sometimes to find enlargement of adenoids in children, usually with respiratory tract infections. But we expect for example, when a child has a flu, you can expect the adenoid to slightly respond to the viruses and become big, but we expect them to come down. But when adenoids remain enlarged for prolonged periods of time, what we call adenoidal hypertrophy, they start interfering with the life of the child. So they start interfering with breathing. They can also interfere with hearing, because remember, with the ears, part of the ear is linked to the back of the nose through what we call suction tubes. And potentially, when you have enlarged adenoids, they can potentially interfere with the function of the suction tube, and you end up with fluid in the ears, and that can cause reduced hearing, and that can also increase infections in the ears for the involved kids. With breathing comes a serious problem, especially when a child is unable to. If they're having episodes where they actually stop breathing at night, what we refer to as obstructive sleep apnea. So what happens is, these are children that you find in general, they've what a parent would refer to as noisy breathing. So noisy breathing is not normal. If it's when they have a flu, then we can presume it's from the infection. But when it's an everyday thing that your child is noisy breathing, it is important that the child gets looked into, partly because it may be the noisy breathing may be coming from the adenoid, and you find that these kids at night they tend to snore. But when with the snoring can also come episodes where they actually are not breathing, which is the obstructive sleep apnea I've been alluding to. What are the issues? They can, as we talk more into it, you actually find that there are serious problems that can come as a result of the obstructive sleep apnea. So adenoids, they become a problem when they're big and they're affecting breathing. They become a problem when they're affecting hearing, or they are causing persistent ear infections, or when they are continually having an infection. And normally those are the kids that you find who are always having a runny a runny nose, greenish mucus coming out of their nose, and so forth. And they can also interfere with speech. That's part of them being a problem. The main thing that you find is the noisy breathing. In English, we would refer to it as stato. As you may know, there are different types of noisy breathing. There's noisy breathing that comes from obstruction from the back of the nose. There's noisy breathing that comes from obstruction a bit lower down, like in the larynx. There's noisy breathing that comes from obstruction lower down the airways and in the chest. So we talk of the stato, which is at the back of the nose. We talk of stridor, which is at the level of the larynx, and we talk of wheezes when it's the lower airways. Now, for the adenoids, it's what we would refer to as stato. All right. This is a child who's like they're snoring, but they're wide awake. So when they are playing around, they're playing, they're walking, and all that, but you can actually hear them breathe in as if they're snoring. That's what an adenoid would cause. It can also, these kids, they can also present with persistently discharging noses, and usually it's discolored mucus, greenish, grayish mucus, and they're always, when you're growing up with these kids that were being referred to as chinyamadziwa and so forth, that can actually be coming from the adenoid. And in some kids, the hearing may not be as good. You may find that in a child, the only thing that may be there is the hearing that's not so good. The child is attending school, but the teachers are concerned if the hearing is okay or not. It may be adenoids. And in some kids, persistent ear infections can also result from adenoids, especially when they form what we call biofilms, which are persistent, which are smart communities of bacteria that are resistant to antibiotic treatment. So, and also the speech, they tend to have what we call hyponasal speech. The tone of it is different from the normal, because they are blocked at the back. So their voices, they sound like, in our vernacular, they'll say someone arunosa. It may actually be the adenoid, that's causing that. We have a common problem, which is the upper respiratory tract infections. Like I said, in kids, it's very common, particularly when they start going to school and when they are going out to play with other kids. They tend to get recurrent infections. So the recurrent infections, can potentially cause issues. Then issues also like allergy. You also find that in kids with a tendency towards allergy, the adenoid may also be a problem, and you can also find it, as a genetic problem. They were born like that, which may be related to allergy or something else, but it can also run in families. And also those kids with syndromes, there are certain syndromes that can potentially make the adenoid sound or look big when it's actually not big, especially syndromes that reduce the space at the back of the nose. You can potentially also get problems, as well as other, congenital anomalies, which are not necessarily syndromes. They can also potentially reduce the space at the back of the nose, and even if the adenoid is not greatly enlarged, you can still get it. It can still present as if it's enlarged. So it's like relative adenoidal hypertrophy. As upper respiratory tract infections are infections that are involving the back of the throat, the back of the nose, the back of even the nose itself, and commonly referred to as flus. The scientific term that we use is pharyngitis, which also includes tonsillitis and your common viral infections. So these are most of them viruses, and a few you find them coming from bacteria. Usually the history, it's usually this. Most of the patients that I see, the commonest complaint is the noisy breathing and the difficulties when sleeping at night, with the obstructive sleep apnea that I was talking about. So with the noisy breathing, this is a child, whether they are awake or they are sleeping, they are always snoring. And when they are sleeping, sometimes they do get episodes where they actually stop breathing. And when they stop breathing, it's usually for a short period of time, and then they start again, and the cycle can repeat itself throughout the night. And particularly for young parents, it can be something that's frightening for them. They can also come in with recurrent infections in the ears, discharging ears, or they can also come in with reduced hearing. And the main complaint, maybe the child is not hearing well, and you examine, you find fluid in the ears, and you look into it, they may actually be having an adenoid. They can also come in with persistent discharge in the nose, and not so many come in with problems with speech. They'll come and tell you, something is not right with the speech. It just doesn't sound okay. And when you ask further, you actually realize it's adenoid. Issue with adenoidal hypertrophy is obstructive sleep apnea. Obstructive sleep apnea is part of the continuum of what we refer to as sleep disordered breathing, where you have snoring on the other end. Now, what is the problem with obstructive sleep apnea? The problem with obstructive sleep apnea is, what's actually happening is because of the blockage at the back. When we all sleep, the tone of our muscles goes down. That includes the tone of the muscles of the tongue. And if you have an airway that's already compromised, any slight change can actually cause obstruction. So initially you get the snoring, okay, which is coming because of partial reduction of the airway, or partial obstruction of the airway. And you can get this obstructive sleep apnea where you actually have complete obstruction. Now, with the complete obstruction, what it essentially means is you are trying to breathe against a closed airway, but your body doesn't stop functioning. It's still functioning. It's still producing carbon dioxide. It's still requiring oxygen. So now what ends up happening is these changes, the carbon dioxide in the body increases, the oxygen goes down because you're not able to breathe. These changes, they cause changes within the vasculature or within the blood vessels of the lungs. And you can end up with what we call pulmonary hypertension, where we are saying with the chronic problems, you're actually getting increased resistance in the vasculature of the lungs, and you end up with what we call pulmonary hypertension. And it doesn't end there. With pulmonary hypertension, because remember from science, the heart has two sides, it's got a right and a left. The right side pumps blood to the lungs. Now the side that is supposed to be pumping blood to the lungs, he has to do more work when there's increased resistance. And with that comes now the risk of heart failure, what we refer to as cor pulmonale, which is right-sided heart failure. It starts off trying to keep up, but eventually it fails. And so you can end up with heart failure. You can also end up with other cardiovascular problems. In adults, we'll talk about hypertension. It's a risk factor for developing hypertension. It's a risk factor for things like ischemic heart disease. All right, and it doesn't end there. With these episodes, remember, this is a child that's not sleeping at night. You think they are sleeping, but they're not sleeping, because if you're observing them, I've seen videos, sometimes mothers are not sure what's going on. They take videos on their smartphones and they bring the videos. If you notice, this is a child that will sleep, they're snoring, and then they get to a point where they stop for a few seconds and they start breathing again. And if you're going to observe this child throughout the night, you'll find that it goes on throughout the night. And what does that mean? It means the child is not resting at night. So they're always tired, they're always sleepy, and sometimes it actually end up with problems with bedwetting. You know, some of the problems with bedwetting are actually coming from problems with obstruction. And in the textbooks, they actually describe even the intellect of the child is affected when one has obstructive sleep apnea. So they liken it, not that there is, I'll just say it as it is from the text. So if a child was going to be potentially become a pilot, they end up just being an average worker in the industry, not because they were not smart enough, but because of the condition that they're having that's affecting their intellect. And also, remember, if the back of the nose is obstructed, this is a child that's going to be forced to breathe through the mouth. Now, remember, the bones of the face are still developing in a child. When you're a chronic mouth breather, the bones of the face will develop to suit your mouth breathing. So they end up with what we refer to as high-arched palates, crowded teeth. When the teeth are coming out, they look crowded, and sometimes they tend to have the upper incisors. They tend to look like rabbit teeth, what some texts will refer to as rabbit teeth. And the face itself becomes elongated, what we end up referring to as adenoid faces. The other issue is the growth is also affected. So you may find that the child is not really gaining weight. Why are they not gaining weight? Because the feeding is poor. Remember, you can't breathe and swallow at the same time. You can only do either, at different times. So you find a child that has difficulties breathing, you have difficulties latching onto the breast, staying on the breast for a long time, because they need to catch a breath each time. So in the end, they're not really feeding well, and sometimes you find the appetite actually also goes down. So, and besides that, there's also the work of breathing. Because they're struggling to breathe, they're using a lot of energy breathing. So you find that they tend not to grow as well as a child who has no issues. The back of the nose, and even if the adenoid is not greatly enlarged, you can still get it can still present as if it's enlarged. So it's like relative adenoidal hypertrophy. The other issue is the growth is also affected. So you may find that the child is not really gaining weight. Why are they not gaining weight? Because the feeding is poor. Remember, you can't breathe and swallow at the same time. You can only do either, at different times. So you find a child that has difficulties breathing, you have difficulties latching onto the breast, staying on the breast for a long time, because they need to catch a breath each time. So in the end, they're not really feeding well, and sometimes you find the appetite actually also goes down. So, and besides that, there's also the work of breathing. Because they're struggling to breathe, they're using a lot of energy breathing. So you find that they tend not to grow as well as a child who has no issues. So the treatment, antibiotics, they tend not to help that much. Most of the cases, when a child comes, they've already tried antibiotics, and they're not really helping. So if there's growth faltering, what we refer to as growth faltering, if there is the obstructive sleep apnea, would want to operate, and also if there are problems with speech. Speech development or problems with the hearing that's coming, because sometimes you find that we actually do ear operations in the same sitting as an adenoid operation to try and address the hearing problems, or in a child with persistent infections which we think may be related to what we refer to as chronic adenoiditis. So the treatment there is surgery. That is where we go and remove the adenoid. I must confess that this is one of the commonest worries or the commonest things that I get asked by mothers with kids that need to go for this procedure. So the answer to it is there is no procedure without complications. But in any medical procedure that we do, we look at the risk factors. We look at the risk, not the risk. We look at the risk versus the benefit. If the benefit outweighs the risk, then by all means. But if the risk outweighs the benefit, then we don't do it. It's not every child that, even when the adenoid is big, it's not every child that we're going to remove the adenoid. So you find there is a small group of patients, particularly those with cleft palate, that we tend not to remove the adenoid because when you remove the adenoid, they end up with quite bad life-changing complications. So you might as well leave them with the adenoid. But in general, yes, there are problems. There are potential complications that can happen. The biggest complication is bleeding, which is usually well managed in theatre, which can happen in theatre. It can happen when the child has gone back home, or even when they've gone back to wherever they're coming from. So bleeding. Sometimes, patients end up with food coming back, what we call velopharyngeal insufficiency, but that you find more commonly in kids with problems with their palate. So as part of the workup to see if the child is fit for surgery or not, we also look for cleft palate. If we find cleft palate, we don't, for that reason. But in general, it is a safe operation to do. I think it's one of the commonest operations that we do. It's quite common. It's just that sometimes people don't recognize it, but it's quite common. In literature, you're talking about 30-34% in the general population, but it can go up if you're looking at patients that are presenting to an ENT specialist. It wouldn't be, my patients would not be a true representative of the situation out there, but in general it is quite a common condition. The adenoid is not the only tonsil tissue that's doing the work of protecting the upper aerodigestive tract. Like I referenced before, there's a ring of lymphoid tissue. So even when you remove the adenoids, when you remove the tonsils, you have not removed everything. There's still some tonsil tissue that's remaining that can still do the same job. But what I would want mothers out there listening to understand is once you start having problems, particularly with the infection, they sort of lose their function. They are not functioning. The function is no longer normal. So you are good without it than keeping it. So removing the adenoid does not really expose a child to infections, no. And like I said, we don't just go about saying every kid must get their adenoid removed, no. We look at what's happening with a particular child. What do they stand to lose? What do they stand to benefit? If they stand to benefit more from removing the adenoid, then we proceed and remove the adenoid. So you find most of the kids that tend to present with, most of them, we try to moisturize the nasal cavity, the nose. And the most common thing that we use are saline drops, which are basically, it's basically salt water that's supposed to mimic the normal fluid that you produce in your body. So the saline drops, and sometimes we use sprays, steroid sprays. Those can also potentially reduce the inflammation. But in the majority of the cases, the solution is to take them out. It differs from patient to patient. In itself, noisy breathing from an adenoid in itself is not really an emergency. that you have to go to the emergency department for it in the middle of the night, but it's something that needs to be looked into. So you find sometimes repositioning the child can help slightly open the airway, and the breathing may be better in a certain position. But then there's no one size fits all, because it also depends on, because sometimes you find enlarged adenoids with enlarged tonsils as well. So there's no one size fits all. It's up to the parent to try and see, with a particular child, if I put them in this position, maybe with the neck slightly extended, can that help breathing or not? Advice is, adenoids, are normal, but they can become problematic, when they start interfering with breathing, when they start interfering with hearing, when they start interfering with speech. It's always important, if you think your child has, some form of noisy breathing, it is important for that child to be examined. To see what the problem is, rather than just ignoring it. Looking back, there are a lot of things that we grew up doing in ignorance. But if we could turn back the hands of time, some people could be somewhere. So my advice is, any noise breathing is not normal. Get help, and the doctors will tell you if you need to do something or not.